Hello, I'm James Palmer. I'm a consultant neurosurgeon, but I also work for NHS England as their medical director for Specialised Services. Every year as a consultant neurosurgeon, I see new treatments coming into my clinical practice. And across the NHS as a whole, there are many treatments that come across all of the specialties that the NHS has to cover. Some of those are very expensive and need to be considered whether they should be introduced or not. NHS England relies on a committee called the Clinical Priorities Advisory Group, which looks across all of the new treatments coming for each of the service areas, and they in turn make recommendations back to the NHS board on which of those to select based upon their relative clinical benefit and their relative cost. So how do the Clinical Priorities Advisory Group, or CPAG, do their work? Well, we'll have to go into a little bit of theory first. Let's plot an x-axis which describes the benefit and a y-axis that describes the cost. Where they cross in the middle, a treatment, if it were plotted here, would have no benefit compared to current treatments, and the cost would be no different to current treatments. So a treatment lying on the y-axis going upwards would be one of increasing cost, and a treatment on the y-axis going downwards would be one of decreasing cost. If you plot treatments on this graph in that way, in the top left-hand section are those treatments of more cost and less benefit. Those in the bottom left are those with less benefit and less cost. Those in the bottom right are those with more benefit and less cost. And those in the top right are those with more cost and more benefit. So looking at each section in turn, let's first look at that top left-hand box. These are the treatments that cost more but have less clinical benefit. We would not want to introduce any of those into the NHS. If we look at the quadrant on the bottom left, which is less cost and less benefit, we might want to introduce treatments in this area, but only if the benefit change was very marginal compared to current treatments. But we would proceed with caution here. In the bottom right-hand quadrant are those treatments that are more benefit for less cost, and we would definitely want to introduce those as soon as possible to the NHS. Most of our new treatments, though, fall in the top right-hand quadrant. These are treatments that cost more, but also provide more clinical benefit. So how do we make decisions about treatments that fall in that top right-hand category? Those treatments that cost more, but give more clinical benefit. Well, we use a technique called the Boston matrix, and you divide that quadrant in that top right into 9 additional boxes, splitting the benefit into 3 categories: low benefit, medium benefit, and high benefit, and splitting the cost into 3 categories: low cost, medium cost, and high cost. So let's imagine that we've got 12 new treatments to consider for investment in the coming year. What we do is we ask the Clinical Priorities Advisory Group, called CPAG, to take those 12 new treatments and look at their clinical benefit. At this stage, they have no idea of the cost of these treatments. They then split those 12 into equal numbers through the 3 categories: 4 in the low category, 4 in the medium category, and 4 in the high category. That CPAG group is made up of doctors, nurses and members of the public, and they make those decisions through deliberative debate and discussion and come to a consensus agreement. Now let's look at the cost. Our finance experts and analytical experts look at the cost of each of these 12 treatments over the course of a 5-year period, and then they're able to rank from the bottom to the top, lowest cost to highest cost, the treatments in order. Furthermore, we then ask them to split those treatments into an equal number of treatments within each of the 3 categories: low cost, medium cost, and high cost, ending up with 4 in each category. Bringing this all together onto the matrix, you can see this 3x3 9-box grid. Take a look at that bottom right-hand corner. Treatments that fall into this category will be those of the highest clinical benefit and the lowest cost. Clearly, This is the priority that the NHS would want to introduce first. Now look at the box in the top left. Treatments that fall into this category will be those with the lowest clinical benefit but the highest cost. Clearly, this would be the lowest priority for introduction into the NHS. Looking across the whole matrix, the Clinical Priorities Advisory Group can recommend 5 levels of treatment priority. As a result, the Clinical Priorities Advisory Group then makes its recommendations to NHS England and its board. They've listed the 5 levels of relative priority and identified the treatments that sit within each of those 5 levels. NHS England's board then knows how much money it has to be able to spend on behalf of taxpayers in the next financial year. And they can then decide how many of those levels of treatment they can afford to commit to. There might be enough money for them to commit to all of the 5 levels, but there might be more limitation on resources, so they might be able to only commit to 4, 3 or 2 of those levels. If some levels aren't able to be committed to in the next financial year, there is always the opportunity for the treatments that lie in those levels to come back to the next Clinical Priorities Advisory Group for a further review in 6 months' time. And these can be reconsidered up to 3 times. We in NHS England have a duty to look at all the new proposals for investment and make sure they're based upon convincing and sound evidence of clinical effectiveness and safety. Furthermore, we need to make sure that our decisions are affordable and the process that we've undertaken is fair and transparent. This process allows us to identify the drugs, treatments and interventions which are the best use of resources and provide the maximum benefit for patients.